All right, our next session is actually two speakers, and they are both representing the American Academy of Ambulatory Care Nursing, which we are very proud to announce that we went into a partnership with this week. Our first speaker is Rachel Stark. She is the Associate Chief Nursing Officer for the Rush System Cancer Service Line. She is the immediate past president of the American Academy of Ambulatory Care Nursing and continues to lead strategic partnerships for AAACN. She widely published on the topic of ambulatory nursing and is the lead editor of the AAACN's first and second editions of the industry report on meaningful measurement of nursing in the ambulatory environment, and is currently conducting her dissertation through Loyola University with 5 organizations and over 150 primary care clinic sites in the country to assess for the relationship between structure, process, and outcome variables in this setting. She has consulted with numerous organizations related to ambulatory nursing services, value-based care, and innovative models of care, professional governance, and emergent roles within nursing. Our second speaker is Cynthia Murray. Cynthia is a board-certified ambulatory care nurse with 3 decades of experience in varied clinical practice settings. She has led the development of expert resources to enhance nurses' professional practice on a global scale as chair and editor for the Scopes and Standards of Professional Nursing Practice in Care Coordination and Transitions Management in 2016, ambulatory care nursing in 2017 and 2023, and telehealth nursing in 2018. Currently, she is serving with the Veterans Health Administration as the PACT and ACT Legislative Action Team Nurse Lead Consultant. Cynthia's contributions to healthcare and veterans' well-being have earned her numerous professional and congressional recognitions. Please welcome Cynthia and Rachel.
I've been taking notes all day, adding on to my presentation, so hopefully we can do this in our time. Thrilled to be here, thrilled to be a partner to this pioneering organization. And I'm just going to say, we know that we're, sorry, a little bit better? Okay.
Yeah.
As we talk nursing, I'm going to use a few notes because I really want to get across some of the pieces I jotted down today. We are here to advocate for a setting that is growing quickly, and you're going to see some of our stats. We believe that we possess answers for some of the value transformation that has to happen for patients. We are in a setting that actually sees patients between 20 and 60 years long, a long-term relationship with our patients, and it is not merely based on an episode, but is actually based on a long-term plan of care if done correctly, right? So I want to just comment on a couple of those pieces as we move through this. We've been given power as nurses by society to own our practice, govern it, improve gaps, further science, so that our service back to patients is improved, so that they receive health. Nurses, we understand this power, but we have had a growing discomfort with the fact that the system in which we practice feels and is unsustainable. Our focus in all of this conversation, I know we're in a moment of real dire need in terms of our workforce, but our focus must be on actual transformation of our whole health system. And we believe nurses, inpatient and outpatient, are critical to actually improving the value that patients receive. With record number of patients lacking access, with creative and science-based solutions lacking the funding they deserve, this system, based primarily on one discipline and on the fundamentals of market competition, is no longer a sustainable option for nurses to practice in. Ambulatory nurses with a legacy of presence in the community, promoting health, preventing disease, improving health literacy, coordinating and reducing fragmentation are critical to the revolutionization of this system. While our profession struggles to understand economies of scale in the inpatient, a setting that does reflect our system's failures to prevent disease, bases its financial models on procedures, illness, and treatments, the ambulatory nursing community is setting a pathway towards autonomous practice of nurses in the management of high-value diseases and populations. With a clear opportunity for improvement of access, equitable care, health, and reimbursement that will continue to grow service and transform from a one-discipline system to a system that realizes the full service that society expects from us. I love this quote from Dr. Yakusheva. I've been using it a ton ever since these articles came out. What I love particularly about this is that what I'm talking about, what we're all talking about today, is the need for positive deviance, to come up with solutions that actually improve health. Moving forward with a focus on value means that we ask the hard questions as a profession. So we're asking hard questions about how we can get reimbursed, how we can get billed. But when we look at outcomes, we also have to be in the present and think about hard truths related to our service and what are those avenues in order to improve that service. We believe it means improving our ability to have access to resources, right? But we must always connect our aim back up to the patients and the society that we serve. Some of this I know is not foreign, but it is the frame from which we're operating in a value lens, especially a lot of our initiatives through the AAACN are focused on improving chronic disease, improving care coordination, reducing fragmentation. So Commonwealth Fund here every couple of years puts out a report. Unfortunately, we're in the bottom right of that screen, lowest on quality, lowest on cost. We do okay where quality is concerned. We don't do as well with duplicative medical testing, care coordination, efficiency. We've been talking about efficiency all over. Our system is based on really, truly one discipline billing, and in effect, many people go without access, even in systems that don't want to give up competition to an APN billing at 85%, right? So nothing against our dear colleagues, person to person, but politically that's a problem that we're focused on one discipline, right? The most sobering is equity here. 40% of patients absolutely choose to not go for whatever test or treatment was ordered for them because they'd rather spend it on something else that's really pressing them right in their face. We believe adding nurses in the community, adding nurses further back downstream will create a system of health. We all know this, but this is a huge boulder that actually we're dealing with. Fixing the current economic model is one strategy now, but thinking about how that can step out to a model that serves patients better, reducing costs on the hospital side will be better for people, right? Okay. So a lot of these citations, I'm sure many of you know, there's been a call for transformation of healthcare, a call for nurses to improve health equity, but we have not had the resources to actually put that in place. It's in the gut of every single one of us. The system is unsustainable, and unless we really put a little bit more money into our service, it's going to be really hard for us to do so. So that's why I'm very excited about all of this work. What we want to talk a little bit about is the value side of where populations are receiving care, drastically changing. And there's been a call for a while for primary care service to be supported. And we believe, especially when you look at this PACT model that Cynthia has worked with, the FQHC world, nurses are autonomously delivering care to prevent disease and promote value because the economic structure allows for that. In my academic organization, not so much, right? So we have to think about some of the models that are working. I want to just talk to you the current state ambulatory care versus acute, just so you can understand, while inpatient is very important, the vast volume is shifting as much and as quick as payers can do it to the outpatient side. Outpatient is not just procedures or encounters. It is telephone interactions, virtual interactions that keep people on a trajectory of health, help them meet their next improved BMI, hemoglobin A1C, right? Hypertension, right? These are interactions that also field symptoms and keep them to the safest level of care. Ambulatory care, which includes outpatient, provided across many settings is estimated to be making around 300 billion worth of encounters, while 60 billion worth of encounters occur primarily in acute care settings such as hospitals. So if we were to think about potentially, we of course are biased. We think there's a clear kind of value argument here in such a deep growth sector where cost avoidance to the hospital setting, it can be maximized to ambulatory sensitive measures, right? And where a lot of interventions can promote health, which reduces cost burden, we believe there's a good amount of opportunity here. And we're going to get into some of the codes that we do already drop, however, they largely give credit to the physician. So we didn't want to be remiss and not tell you who we think the ambulatory nurse is. And you can get any of this content, the role of the ambulatory nurse, lots of our reports on our website. We practice across diverse settings, including traditional medical specialty, community clinics, urgent care, correctional, pharmacies, school systems, college university clinics. You can see the list here, procedural, military institutions. The role of the RN in ambulatory care focuses on maximizing quality health outcomes. So this isn't just a person, and in many cases, that rooming is not even occurring by an RN, right? This isn't just a person that sees you, checks a bunch of boxes, and then leaves. In the systems that we're looking at and that we're writing about here, they're managing a cohort of 3,000 to 5,000 patients at a time, looking at their metrics on a daily basis, doing virtual or outreach to those people to keep them healthy. So population health, preventative health, primary care, mitigation of health disparities, consideration of social determinants, educators, chronic disease management, care coordination. So the current state of billing in our world, still lots of opportunity. We are unable to bill directly for services. Services can be billed incident to, and our dear colleague who couldn't be here just wrote an awesome little blurb or op-ed in LinkedIn about how nurses are not incidental to, but instrumental to. It was awesome play on the words. But evaluation and management codes don't specify who can perform this intervention. A lot of that's left to state regulations and guidelines. Unlicensed staff who have very few regulations compared to RNs are involved in care as well. CPT value in the world that we've been talking here, I think has opportunity. We provide complex service, but no provision of value has been dedicated to those services. When you think about 99211, which we talk about, we've written a lot about because we're proud that the nurse is contributing in ambulatory, but those are all giving credit back to the physician. They require direct supervision, and really, truly, we haven't defined in the ICU that a nurse needs direct supervision, so why would we be doing it for chronic or preventative care in the outpatient, right? So we have to be thinking about some of those conceptual things as we advocate for this work. There's an assumption that the 99211 is not medical decision-making, so there's lesser value placed to it. Result of the current pay model, RNs are invisible. This is again themes from throughout today. We do contribute to quality and cost efficiency. We are, even in my system, and I believe academics are kind of the furthest behind leading. I'm at Rush, furthest behind in the leadership trajectory. We are even moving nurses because we sense that there's a cost avoidance back to the hospital, right? But they are still perceived as a cost, even if they're doing activities that support that work. Practices recognizing this value are faced with insignificant revenue to support this RN investment, so we spread a nurse amongst several practices at a time and expect that oversight to happen there. Increasing pressure on primary care to improve quality, significant underfunding is, again, a system reflection. There's so much value on the procedure, on the disease right now, on the treatment, on that chemotherapy drug that's $60,000 one time times 12, right? So if screening and health prevention was way